Hello, my name is Ravi. I'm from My Cancer Haven, and today in the Conversation with Cancer Expert series, we have Dr. Ajai Chari, Professor of Medicine. He's Director of the Myeloma Program at one of the premier myeloma institutes in the United States, the University of California in San Francisco, and he's going to give us updates on the DREAM7 and DREAM8 studies that came out at ASCO and EHA, and tell us whether we are ready for the return of Belantamab Mafadotin or Blenrep. So welcome, Ajay.
Thank you, Ravi, for having me. It's a pleasure to be here.
So Ajay, obviously, Blenrep is not really a new drug. It had been on the U.S. market, was withdrawn, I think, a couple of years ago. It has obviously still remained available for those who were benefiting, and some select patients are still on it, but we've not had new starts on this for a long time. So it'll be great to review the data that came out and see how you put this in context and how you see this being incorporated at a future date in your practice. So we'll start out with the DREAM7 study. So could you just tell us, a little bit about the study design, and then we'll come down to the results.
Sure. Well, first, I think just to put the Belantamab history in context, it was initially approved for accelerated approval, but then the DREAM3 study was Belantamab monotherapy versus Pom-Dex as a doublet. And even though there was an efficacy signal, it didn't meet the statistical endpoints, and there was also a REMS program for the ocular toxicity, so it was withdrawn. And what's really unique about 7 and 8, it's refreshing, it's a breath of fresh air to really see triplet versus triplet, right? Because for the last probably 10 to 15 years, we've seen triplet versus doublet. And of course, they're positive studies. And then we saw monotherapy versus doublet was a negative study. So what's unique here, this is actually triplet versus triplet. This is Belantamab with bortezomib and dex versus the control arm was daratumumab, bortezomib and dex. We can pontificate on whether that is the best control arm or not, but let's at least acknowledge that it's triplet versus triplet. And the VD is the same in both arms. And then it's twice weekly, as no one loves that, but it's cycles 1 through 8, 3-week cycle. But Belantamab is given IV every 3 weeks at 2.5. And then it goes to monotherapy after that versus Dara monotherapy. And that also is unique because often there's only one drug that gets maintained in the experimental arm and the control arm has nothing. So this is triplet with de-escalation till progression versus triplet with de-escalation till progression, with the primary endpoint of being PFS, with a good follow-up of 28 months. And this is 1-to-1 randomization. So I think the study design is refreshing in itself.
So what can you tell us about the primary endpoint?
So what's great here, we see that these PFS curves separate quite early, and the green curve remains nice and flat with a median PFS really impressive of 36 months. Control arm was only 13.4 months, which is not that different from CASTOR. So many may remember DVD versus VD was the CASTOR study that led to Dara bortezomib dexter approval. And the PFS there was around 16 months. Now, again, we always hesitate doing cross-study comparisons, but this PFS is not way out of the ballpark. So they picked an active triplet, and yet the hazard ratio is 0.41, meaning 60% improvement in the likelihood of adding the likelihood of adding Belantamab to bortezomib dex compared to Dara. And in a way, showing that if you go head-to-head with the VD backbone, an anti-BCMA ADC actually beat daratumumab, which is a great drug in and of itself.
Yeah, that I think is certainly no mean feat. And what would you say about the survival curves?
So I think what we know from the health authorities is with the increasing amount of salvage options, we can't always expect OS benefit because you can keep salvaging people. So first thing I look for in OS is there harm? And definitely not. You see that the green curve triplet experimental is over the gray curve, the control triplet. But not only that, it's actually 0.57 hazard ratio and doesn't cross 1 and statistically significant p-value. It's a trend because probably didn't meet the pre-specified cutoffs, but this is definitely very encouraging. So not only are we not seeing harm with Belantamab, we're actually seeing a trend towards OS improvement, which I think is great to see and consistent with the efficacy PFS translating into OS.
And obviously, one of the key secondary endpoints was the depth of response, and it appears that the experimental arm did better there too.
Yeah, I agree. I think overall CR and MRD negative. I think one interesting thing that in myeloma that we need to start looking at is we know the ODAC voted favorably that MRD can be used as a surrogate endpoint in randomized clinical trials. And we do see here that whether you're using 10 to the minus fifth or sixth, we're seeing that improvement. But what I think is going to be important for us to understand as a community is what MRD negativity will actually translate into a PFS. So here we're seeing 38.7% versus 17% for VGPR and better, and CR and better, 25 versus 9. So maybe like a little bit over doubling of the MRD negativity translated into that PFS benefit. So that's something we're going to have to start filing away, but it's great to see. In a way, you don't really need MRD negativity if you've already seen the PFS, but it's good to see.
So, and this was a heavily pretreated population of patients. And at the ASCO meeting, there was an update on subsets that we will go over. The data had been presented at a special ASCO plenary meeting a few months earlier. So, what is this population that was studied?
Yeah, so first, when we look at the prior lines of therapy, the median looks like it's going to end up being around 1, right? Because it's 50% in both arms had only 1 prior line of therapy. And a third had 2 or more, and then maybe 10% had 4 or more. So not as heavily treated as some of the other studies that we've seen. I think the other important things to pay attention to in this are prior DARA and prior lenalidomide. And so prior IMiD was 81%, but when you look at prior len, it's 50%. Because a lot of this was probably in Europe where there was thalidomide exposure. Prior DARA is very uncommon. And of course, that makes sense because your control arm is DVD. So if you had a lot of patients exposed to DVD or DARA and were refractory, you wouldn't enroll them on this study. But that's going to be important when we interpret the context of these results. But drilling down in particular to len refractory, which is a huge issue in relapsed myeloma because of the increasing use globally of frontline lenalidomide till progression, we see that refractory to lenalidomide in the BVD population, B for boy, is about a third of patients and comparable to the DVD. But as you get more heavily treated, that goes up to about 40% in both arms. So there is a reasonable len refractoriness here, and that's always something to look for, particularly because we'll see with Castor that didn't do very well.
So in this subset analysis presented at ASCO, what did they show?
Well, first interesting thing is if you look at the control arm, if you're not len refractory, your PFS is pretty good, right? It's about 16 months. 18 months, my aging vision. But the control arm does pretty poorly. It's only 9 months. And that's a similar message to what we saw in Castor. So even though you're picking a non-cross-resistant regimen, daratumumab, bortezomib, and dex theoretically should work in len refractory patients, but you can see while it may work, it doesn't work as well. And yet, when we look at the experimental arm, that difference is not as dramatic. There is a difference. So it's about 37 months versus 25 months, but 25 is still not bad compared to the control arm on the left of only 9 months. So the hazard ratio is actually even better, 0.31. So in other words, when you take a VD backbone in a len refractory patient, the addition of belantamab led to a 70% improvement in the likelihood of progression. So that's pretty good. And I think shows the non-cross resistance.
And the other group that was analyzed was the high-risk cytogenetics group. And I guess this is another analysis that is always worthy of making in these trials.
Absolutely.
So what can you tell us about how belantamab performed in this population?
So again, if we start with the control arm, there's a way to check your work. Was high risk really high risk? And you can see on the right, 15.3 versus 10. And so, yes, there was a difference for high risk with DVD, high risk versus standard risk. But what's fascinating is Bela VD is not that different. 36.6 months versus 33.2. That's almost overlapping. And that's really nice to see because what we look for in high risk is, are you just improving the outcomes? Are you overcoming the high risk? And there's a suggestion here that belantamab may do quite well for these high risk patients. So that's nice to see.
And we'll talk a little bit about the toxicities, at the end once again, and how to manage them. But what do you look for when you look at the toxicity tables in a trial with belantamab?
Well, first is that when we look at the AEs, we have to keep in mind that because the PFS is much longer, you're going to see more AEs always in the experimental arm. And ideally, you want to look for some kind of exposure adjusted analysis. But here we see that the AE rates are, kind of what you would expect, that you would see cytopenias with the addition of belantamab. And we see ocular changes. High grades is an important thing that we need to pay attention to. But at the raw level, we do see, I think the main things being highlighted here are the thrombocytopenia and ocular issues.
So we'll, come back to discussing how this is going to impact your practice when it reappears on the horizon. But before we do so, let's just talk about the DREAM-8 study, which was the first presentation of the DREAM-8 study. So can you, to our audience, just talk about the trial design here?
Sure. And one other quick point I'd like to make on DREAM-7, if I may, which was that one of the unmet needs is actually the double refractory population, right? So we saw maybe a third of patients were Len refractory, but we don't have DARA refractory because of the nature of the study design. And that's huge because where these patients are going to get treated, I think the true value out of belantamab is the fact that it's an off-the-shelf product that does not require hospitalization for CRS management, does not require a specialized academic center. So it'd be nice to have had more Bela patients data with double refractory to DARA and Len, because that's where our unmet need is, right? Maya, which is frontline DARA Len Dex, does beautifully, improve PFS and OS, but the problem is that how do you salvage a DARA Len refractory patient? And I think DREAM-7 doesn't tell us that. So we can look at DREAM-8 here, which is a slightly different question, because here the control arm is Pomdex with the addition of bortezomib. So this would be the so-called optimism study, PVD or VPD, depending on what alphabet you like first. And then there's belantamab Pomdex as the experimental arm. Here, belantamab is given at 2.5 the first dose, but then it's dropped down to 1.9. And one of the things we know about a lot of these newer targeting therapies, both CAR-Ts, bispecifics, and ADCs, you got to capture the disease, but particularly with the ADC and bispecific, because of the cumulative toxicity that you can get after that first dose, can you back off on the dose intensity? And so this is an attempt at belantamab to not give the full dose constantly, but reduce the dose a little bit. Same primary endpoint PFS.
And what was the population accrued here?
Here we can see in terms of the time since time of relapse after first line therapy, most of these patients were relapsing over a year. So, but there's about 15% of patients that had what we call functionally high risk. Also about 10% had extramedullary disease, but the kind of typical relapse myeloma, and these were about 4 years out from time of diagnosis.
And what kind of population was accrued in terms of prior therapy exposure in this study?
So again, similarly, there's one prior line of therapy is probably the median because both have about 50% of patients getting that. And a third of patients get two to three, and maybe about 10% or 15% have more than 4 lines of therapy. In terms of prior transplant, this is about 60%. And that's again important to consider because belantamab targets a BCMA, B cell maturation antigen, and another option for BCMA targeting, of course, is CAR-T. But getting back to the patient population, this is 100% immunomodulatory exposed and very high lenalidomide exposure, both arms at 100%, and about 80% were Len refractory. So this is a more Len refractory patient than DREAM-7. And that's true because most Pomdex studies are enrolling in Len refractory patients. And when we look for DARA exposure, we do see about 20% of patients have that DARA exposure, which is, again, that unmet need we're looking for post-Maya.
And how did this regimen fare?
So again, the PFS curves separate quite early, which is nice to see. Green is consistently above the control arm. The median PFS is not even reached with the green. This is with follow-up of around, I want to say, I think 20 months. But the PFS hazard ratio is about 0.52. So again, almost 50% improvement over VPD. And again, this is a triplet versus triplet, not the usual triplet versus doublet. So the fact that on a VD backbone, you can either get a benefit from adding bortezomib or DARA, but belantamab beats both of those in these two separate studies is the consistent message that's coming out.
Once again, I guess the depth of response favored the experimental arm.
Exactly. And it's 1-to-1 randomization. So yeah, improved depth, CR, overall response.
And again, similar comments regarding survival.
Yes, and here because the follow-up is shorter, and we don't there haven't been as many events, the hazard ratio crosses 1. But again, the main thing is there's not a harm, that the OS for the triplet with belantamab is superior to the VPD.
Are you in relapse refractory trials looking at OS and hoping for an OS benefit? Is that something that in the absence of an OS benefit, you still feel that the presence of just a PFS benefit is sufficient to move standards of care?
I think those days are really gone. I mean, when I was a fellow, thalidomide and bortezomib were just coming on. There, you could expect a relapse study potentially to show OS. But now, with 3 IMiDs, 3 PIs, 2 naked antibody CD38, BCMA bispecifics, CAR Ts, selinexor, I think mainly we want to make sure that there's no harm. And it is important to talk about that because we have 3 examples in myeloma: checkpoint inhibitors, venetoclax, and melflufen. 3 agents where we saw better response, where we saw better PFS, but the OS was not supported, and there was even harm. And so I think those 3 were all withdrawn and don't have an approval for myeloma. So I think we should definitely be looking for lack of harm, but I don't always look for benefit, and definitely not statistically significant. And here, I would be okay with this, even if this hazard ratio remained like this, because it just shows that there's no harm coming, and if anything, it's trending in the right direction.
And if any comments do you have on the subset analysis that accompanied this presentation?
So I think, again, that high risk is interesting, similar to DREAM7, that even the high risk highlighted here had a comparable benefit. Of course, I don't like forest plots. I would like PFS Kaplan-Meier curves, because it'd be nice to see if high risk PFS is exactly sitting on top of standard risk. But within the high risk, the experimental triplet did better, and pretty much all the categories. And it's nice to see, actually, it's impressive that, this was only a 150 patient per arm study. And despite that, with all these subgroups, which tend to be small, the confidence intervals are generally stacking to the left of 1, with probably the exception of EMD, which is a very small patient subgroup. So I think this is nice to see that looks like all patients subgroups are benefiting with the addition of belantamab.
And seems like the refractory to lenalidomide and refractory to CD38 group seem to benefit as well.
Yeah, I mean, the refractory to lenalidomide is very clear that hazard ratio is nice and tight. It's pretty much all patients. So you can see that you would expect the hazard ratio to be very comparable to the intention to treat overall population. The CD38 is a little bit more dirty, right? That hazard ratio does cross 1. Again, is small numbers, but I would have liked to see that kind of truly double refractory population. It'll probably be close to this DARA refractory because the majority of patients were len exposed and refractory. But it'd be nice to see that a priori, because I would say one of the unmet needs in MAIA, the PFS is outstanding, but the OS of MAIA sits almost on top of the PFS, which means if you have a transplant ineligible patient and you're giving DARA-Len-Dex frontline, how do you salvage that patient, right? And these are older patients who are now to 5 years beyond what they were diagnosed. So you're taking MAIA was, say, 73 years on average, and now they're 78. How do you salvage a 78-year-old patient who's DARA-Len refractory? We're not excited about a lot of the other options. So it would be nice to really have even a small phase 2 study, I think, to show that this subgroup does well. But I think this is really the unmet need, but encouraging data for sure.
And anything unique in the toxicity profile in this study that it bears mentioning?
No, same cytopenia, same ocular, which I think is going to be important to contextualize this data. But the one kind of other unique thing here that's provided in this data set is the infection signal. And you can see that on the left, the first column, it looks like there's a higher rate of infections on Bela versus bortezomib PD. But when you adjust for time on therapy, which is where the patients per 100 years, those numbers are actually quite comparable, which is fascinating because generally we think of like BCMA or CD38 targeting therapies causing more infection risk, but we're not seeing that here. And actually think that absence of a market infection signal is quite encouraging. Of course, we do see the ocular issues, which I think something that I'm sure we're going to talk about.
So let's put it all together for us. So how did you use belantamab when it was initially on the market?
I participated in the clinical trials. I think we did see that if you go back to the phase 1 dose escalation studies, you need to start at the recommended starting dose, because if you start too low, you don't get the disease control. And we know that you got to start. No drug has 100% response rate. So there's that initial starting dose. But we also learned that it's impossible to give it at that starting dose on an every 3-week schedule. Everybody has holds, reductions, pauses. The interesting thing about this molecule, though, is that as you can kind of see from the PFS curves, and it's also, we didn't show them here, but the DOR, when you give belantamab, if the patient responds, skipping a dose or two is really super well tolerated from an efficacy perspective. It's not like, oh, you hold the dose and suddenly the disease goes back. If anything, I think the durability allows you to skip doses and it allows you to adjust the schedule for the patient's ocular issues. So I think that's what was really nice. But I guess I would say one of the challenges is that we'll have to see, and this goes to kind of like the second kind of question and third question, which is the FDA did put in place initially a REMS program. And, REMS is always this deterrent, I think, for community doctors who are busy. They have to do the training, and then their team has to do the training, and then you have to work with an ophthalmologist. But we'll have to see how the health authorities vote on this, whether there's a REMS program again. My suspicion is there probably will be, because we would need a reasonably sized prospective data set to show that you can give belantamab without doing ocular exams and using only patient-reported outcomes to give a schedule that is well tolerated. And while those data sets are being generated, we've heard from, for example, our colleague Dr. Turpos in Greece doing only a patient-reported survey and finding that using the changes in vision, you can actually kind of give the dosing and schedule in a way that does not generate a lot of severe AEs. But my challenge with that is always that people who do better, right? Like if you're only reducing it in responding patients and you're doing it at a high volume academic center, so of course people are going to do well. I think to really generalize this to the community, I would love all clinical trials and new agents to move away from what we're doing. And what I'm getting at is that our current myeloma strategy of accelerated approval always pushes the dose intensity to get that response. And what that inherently does is it prioritizes efficacy over safety and toxicity. And I think what we need to do, especially for these agents, is have an induction dose and kind of a more maintenance dose, and show that you don't make patients and physicians go through phase 1 dose escalation studies at the bedside, right? Like, I don't think anybody wants to be like doing these complex ocular exams, talking to their eye doctor, trying to interpret their mumbo jumbo, because none of us read ophthalmology jargon and they're like, wait, what grade corneal damage are you saying here? And so it'd be nice to just have a prescriptive, start with this dose, drop it to this dose and frequency, and then only see the eye doctor if this happens. That would be a winning combination. But right now, I think it's going to be not quite there yet.
So obviously dose reduction is one way, and the other way is to give the drug less frequently, given the fact, as you said, prolonged holds have seemingly not affected the efficacy of the drug in some of these data sets. So giving your past experience, which do you think is a better strategy? Or is it going to be individualized to a patient in your practice if and when you use it again?
The fact that Dream 7 versus 8, you see the difference already, I think it'll be impossible to give everybody full dose on every 3-week schedule. So I think you probably need, but there were also studies that showed that if you didn't give that first dose, you don't get that response. So I think probably 2.5 starting dose is reasonable. And then maybe going to an every 4 to 8 week schedule after that. And especially when you have other drugs, right? There's a difference between belantamab monotherapy versus using backbone agents that are also helping you achieve that disease control. So you don't need that dose intensity of belantamab. So I think after maybe 1 or 2 doses, my prediction is we'll go to an every 2 to 3 month schedule at a lower dose. And that'll probably be the kind of maintenance dosing.
And so we have a number of BCMA-based treatments now on the market. And how do you think this will fit into your practice? And do you think it will have a differential role in an academic practice compared to a community physician's practice?
Yeah, I think in some ways I'm probably the wrong audience for that question, but I think if you had to pick, so the 3 categories, of course, you're referring to are CAR T, bispecific, and now we have the antibody drug conjugate. I think if you had to prioritize those, CAR T, particularly cilta-cel, has the single best efficacy we've had of any agent in myeloma. In heavily treated patients, 6 lines of therapy, 98% response rate, PFS is almost 3 years. So with that, what that also means, I think what's not completely conveyed by just those numbers is the treatment-free interval, right? So after you give CAR T, one of the most rewarding things for a patient is really being potentially off all therapies for 2.5 to 3 years, because yes, there's some cytopenias and IVIG and all of that, but most patients, I would say, after 3 to 6 months would be off all therapies. So if a patient is CAR T eligible, then I would say that probably should be done. And just a cautionary tale of how belantamab affects that, those numbers I cited, those PFS goes from 3 years to 9 months in that small data set. But when cilta-cel was studied after prior ADC targeting BCMA, that PFS really dropped. So I would say number one message is before starting a patient on BCMA, check with your collaborating academic center to see if at all this patient is CAR T eligible, because you don't want to do anything to compromise that 3-year PFS, which is so rewarding for the patient and also expensive, right? If you're going to do CAR T, you might as well get that big bang for your buck. But I would say the next then decision point is this patient's disease explosive or not? Because if their disease is super explosive, many of these patients may not get to CAR T, right? Because I think what we saw from CARTITUDE-4, KarMMa-3, even in 1 to 3 lines of therapy, you can randomize a patient to CAR T, but if their disease progresses before they get to CAR T, you have higher rates of CRS, ICANS, neurotox, and death. So I've always said it's better to be alive on a bispecific than dead on a CAR T waiting list, right? So I think that explosive disease is the next big thing. And also we have to keep in mind in the US, probably depending on the data set, most 10 to 20% of patients are getting stem cell transplant. CAR Ts are even more expensive and more restrictive. So it's not going to be, vast majority of patients are not going to be getting CAR T. So I think bispecifics are there, but I think the challenge with the bispecifics is that infection signal with BCMA. With the most mature data set of teclistamab, with over 2 years follow-up, the rate of all grade infections is 80%, and the rate of high-grade infections is 55%. We're talking serious pneumonias. I had a patient with pericardial tamponade from a weird Neisseria subspecies. So we contrast to the belantamab studies, you don't see these kinds of crazy grade 3 infections. So to me, that would be the next decision point, is if somebody's infection prone, fragile, elderly, if we can get that ocular story straight, there's every reason to believe that belantamab would be really viable option for particularly community centers where you don't have to deal with admission for CRS or CRS management, and it's an off-the-shelf product. So I think it's great for patients and community to have an option that they can do, because the vast majority of myeloma patients are not being treated in academia. And that's where this drug really has a huge potential in the market.
And obviously, we are going to potentially have in several patients the option of exercising BCMA-based treatments in more than one line of therapy. Do you see a role for this in retreatment for patients who've had prior CAR T or prior BCMA?
Great question. Historically, we've done a terrible job of retreatment in myeloma, right? I think probably the only drug that I can think of in the last 15 to 20 years is bortezomib, and it's because it was hard to give bortezomib until progression. So there were studies showing that if you were responsive, you can have a break and retreat. But the majority of other drugs are often used to progression, so we don't typically go back to them. And I think the devil's in the details, which is there is different components of retreatment. One is what happens to the immune microenvironment. So, for example, if you give bispecifics till progression, you may get T cell exhaustion, which may then preclude a CAR T, for example, downstream. Then there's the impact on not the microenvironment, but the tumor. If you give repetitive BCMA targeting therapy, whether it's an antibody drug conjugate or bispecific, might you then engender some kind of a change in the tumor, which could be either genomic loss of BCMA or, based on some recent publications in Nature Medicine, could it be a protein change, right? If you change BCMA conformation, that could affect downstream sequelae as well. So I think, and the third part is we have more than BCMA, right? We have GPRC, FcRH5, we have dual targeting. So do you need to keep repeating the same target when you have other options? So I think we have a lot more questions than answers to that question, but probably what we do know right now from a BCMA perspective is that biallelic loss of BCMA is relatively uncommon. And certainly after CAR T, I think that sequence is better. I think if you get a BCMA CAR T, you can probably then do subsequent BCMA targeting therapies by definitely by BCMA bispecifics. We've seen pretty good results. ADC, I don't think we have as much data, but I don't see clinically, from a theoretical perspective, how that would necessarily be a problem. And I would add lastly that one of the unique parts of an ADC is if we can use these sequentially, if you're not depending on T cell function, might this be the best way of giving patients a respite? Like if you want to go from a bispecific to a bispecific, is that intercalating therapy, should it be an ADC to let those T cell recover? I think that's a really exciting question that we don't yet have a lot of data for.
Well, Ajay, I want to really thank you for spending the time to educate the audience about this set of data and how you think this may help patients in the time to come. I'm always, very grateful for your astute and eloquent delivery. You always have some very unique perspectives that I must say that I've always enjoyed and respected. And I hope I can have you back on a future program to talk about another topic in myeloma.
My pleasure. Thank you for you and your team for all the work you're doing to educate the community and patients.
Thank you.